For anybody on the call that doesn't know me, I'm Mark, one of the second-year cardiology fellows, and I figured we could talk about the perioperative use of SGLT2 inhibitors, as this is kind of an increasingly prescribed medication with some nuances in the perioperative setting. So the I guess article I sent out is this one titled Perioperative Management of Patients Receiving SGLT2 Inhibitors, development of a clinical guideline at a large academic medical center. And as you can see from the authors here, the academic medical center was UPenn. So I figured we could just briefly go through kind of the mechanism that drives ketoacidosis, then kind of look at the incidence of ketoacidosis in the perioperative setting in patients who are taking SGLT2 inhibitors, then kind of review this paper, and then finally talk about, what you do if you happen to catch a case of euglycemic DKA in the perioperative setting. So to start with a background, there are various definitions of DKA, but the American Diabetes Association and UpToDate seem to converge on, these general lab values. So they tend to notice it if the glucose goes above 250, the pH drops below 7.3, the bicarb is less than or equal to 15, with the presence of ketones in the blood and urine. And normally, our cells are happy if they can get some glucose inside of them, and the way we typically get glucose inside of our cells is by having insulin bind to an insulin receptor, which then promotes the shuttling of a glucose transporter to the cell membrane, which allows glucose to enter the cell. And once the glucose gets inside the cell, it can get converted to acetyl-CoA, which can drive our Krebs cycle and produce some energy. But for patients who don't have insulin around, that glucose transporter stays bound to a vesicle inside the cell. The glucose can't get inside the cell, and then our body looks for other ways to generate acetyl-CoA to drive the Krebs cycle. And the next molecule up is fatty acids, which get broken down to acetyl-CoA via beta oxidation. Unfortunately, the same process that breaks it down to acetyl-CoA also clogs up the TCA cycle, not allowing the acetyl-CoA to enter, and then the acetyl-CoA ends up going on to form ketones in the form of beta-hydroxybutyrate, acetoacetate, and acetone. And these ketones are proton donors, which then drive down our blood pH, drive down our serum bicarbonate, and then obviously their presence leads to ketonemia and ketonuria. And it turns out this process of beta oxidation has a few more steps, but one important one is that fatty acids get broken down to free fatty acids by an enzyme called hormone-sensitive lipase, and the hormone that hormone-sensitive lipase is sensitive to is the arch nemesis of insulin, the counter-regulatory hormone glucagon, and glucagon promotes beta oxidation by stimulating hormone-sensitive lipase, and insulin inhibits it, and thus prevents beta oxidation and thus inhibits ketogenesis. You might wonder why our body wastes its time making ketones, and the main reason is that the fatty acids that are produced, or the free fatty acids that are produced by beta oxidation, can't cross the blood-brain barrier. So we use ketones to get that acetyl-CoA to our brain cells, which can then go and drive the Krebs cycle and create some energy for the brain when the cells in the brain can't see glucose. But ultimately, it's this ratio of high glucagon to low insulin that promotes beta oxidation and thus ketogenesis, and therefore states that drive up the counter-regulatory hormone glucagon, such as fasting and stress, which we might see in the perioperative setting, or if you have diabetes and just don't have much or any insulin around, these things will promote ketogenesis. And it turns out that SGLT2 inhibitors promote the renal reabsorption of ketones and therefore exacerbate the ketonemia and ketonuria, driving down the pH and bicarb even further. And it turns out that glucagon also promotes gluconeogenesis and therefore results in even higher levels of glucose. But if you have SGLT2 inhibitors around, which promote the renal excretion of glucose, it will confuse some doctors because it will drive the glucose levels down, oftentimes even below 200, while the patient is still very acidotic, creating this environment of euglycemic DKA. But I figured next we could talk about, the incidence of this euglycemic DKA occurring in various settings, in states of fasting and stress, such as, the perioperative setting, and in patients with and without diabetes, and in those taking SGLT2 inhibitors. So recently, we all got a update that the FDA made some recommendations that we should hold these SGLT2 inhibitors for at least 3 days before they're going for a scheduled procedure. One group in 2017 said, we see your recommendations, but let's see where this data is coming from. So this group decided to take a look at this FDA adverse event reporting system. And what they did is they found all of the cases of DKA in patients who were taking an SGLT2 inhibitor, and they found about 2,500 cases. And what they saw is that over time, since 2014, the incidence of DKA in patients taking SGLT2 inhibitors has been going up. I wouldn't get too excited about the fact that there's a gap between the patients with diabetes and the total, because there was just a good number of patients in whom they just didn't report their diabetic status. But at the end of the day, it turns out if we look at how many of these patients with ketoacidosis who were taking SGLT2 inhibitors were dying as a result, you can see that the rates are incredibly low. Your eyes might be drawn to the second quarter of 2014, where it looks like the percentage is higher, but that's just because the incidence was so low. There were really only 4 cases reported, and unfortunately one of those patients died. But we can see that, as the number of cases we're recognizing has gone up into the thousands, the incidence of death as a result remains quite low. The New England Journal in 2017 put their number at about 4.9 cases per thousand for patients who are taking SGLT2 inhibitors. And in 2023, there was a doctor in Japan, Dr. Seki, who decided that he wanted to do a systematic review to see how frequently this was really occurring. And he noted that although the recommendation from the FDA was to hold the SGLT2 inhibitors for 3 to 4 days, the validity of this recommendation hadn't been verified. So he went through the literature and found 99 cases of ketoacidosis up to June of 2022. He included patients who had a pH less than 7.3, who had ketones in the blood and urine, but he excluded patients if their pH didn't drop, even if they did have ketones. And what he found is that since 2014, since SGLT2 inhibitors started becoming popular, we do see increasing number of case reports of perioperative ketoacidosis in patients taking these meds. In particular, you'll note that 97% of these patients had diabetes, the majority of whom had type 2 diabetes. And even though you might think that 3% didn't, once again, it just wasn't reported. So it's not clear whether these patients had diabetes or not. When they noticed the DKA, it was most common to notice it on postoperative day 1. And the most common thing that made the doctors realize that ketoacidosis was present was lab abnormalities. And in particular, they found that these patients had a median pH of about 7.1, a median bicarb of 9, a median anion gap of 23, and the median glucose was below 200 with a median of 179. But this same Dr. Seki, a year later, said that as the number of SGLT2 inhibitor associated perioperative ketoacidosis reports continue to grow, it's clear that retrospective examination is insufficient and that prospective studies are required to accurately identify these cases. So that's what he set out to do, and he basically found about 750 patients across 16 sites in Japan between 2021 and 2022, all of whom had type 2 diabetes, or not all of whom, I guess 98% of whom had type 2 diabetes. And he excluded patients who had held their SGLT2 inhibitor for more than a week, were not undergoing general anesthesia, or if they had the presence of DKA at the time of screening or anesthesia. And what he found was that the estimated incidence of SGLT2 inhibitor associated postoperative ketoacidosis was 0%. And this was despite mixed adherence to the withdrawal guidelines. No cases of SGLT2 inhibitor associated perioperative keto, or I guess I should say postoperative ketoacidosis, were observed even in the 35.4% of patients who discontinued their SGLT2 inhibitors less than 3 days from the procedure. And if we look at the procedures that these patients were undergoing, we see that the majority of them were fasting for at least 12 to 24 hours, and that 35% of them had just stopped their SGLT2 inhibitor 1 day before the procedures. And once again, none of these patients went on to develop ketoacidosis. So that kind of leads us to the paper that I sent out from the University of Pennsylvania, Perioperative Management of Patients Receiving SGLT2 Inhibitors, Development of a Clinical Guideline. And they note in their paper that to date, there have been no cases of DKA in major published trials of SGLT2 inhibitors for cardiac or renal indications in patients without diabetes, and that although the FDA guidance currently makes no distinction based on indication, patients taking the medication for a cardiac or renal condition in the absence of diabetes do not appear to have a significant risk for developing euglycemic DKA. And I'll just point out that they published this in January of 2024. And again, their thought was that, if the mechanism of creating ketones is this high glucagon to insulin ratio, you could imagine that patients who don't have much or any insulin around are going to be particularly prone to this, but that if you do have insulin around, it might be able to counteract this process. Unfortunately, about 1 day after this was published, you get a case report titled Euglycemic Ketoacidosis in 2 patients without diabetes after introduction of SGLT2 inhibitors. And they say, here we present the first 2 descriptions of severe ketoacidosis in patients without diabetes after treatment of SGLT2 inhibitors for heart failure. Going through the 2 cases, the first is a 28-year-old kid who's got Duchenne's muscular dystrophy, and he was coming in after 5 days of gastritis, 2 days of nausea and vomiting. And because of all this nausea and vomiting, he had actually not taken his dapagliflozin for 36 hours prior to presentation. But when he showed up, he had a pH of 7.1, he had ketones in the blood, he had an elevated anion gap, his glucose was only 70, and they tried to prove that he really didn't have diabetes because his A1C was just 5.2, and then they even measured his C-peptide and showed that he was pumping out lots of C-peptide, indicating that his pancreas was capable of producing lots of insulin. And they noted that he was managed with an insulin dextrose infusion, that no insulin was given for the first 12 hours because he was so hypoglycemic. And they noted that his just giving him dextrose actually dropped his ketones from 5 to 2, which they figured reflected the fact that his endogenous insulin was kicking in. And they also noted that despite the fact that he hadn't taken the med for 36 hours, he still had a lot of sugar in the urine, which suggested that there was ongoing effects of the dapagliflozin, even 36 hours later. The second case is a 62-year-old woman who just had newly diagnosed heart failure with reduced ejection fraction with an EF of 35%. And she came in with altered mental status and a severe anion gap acidosis 1 week after a diarrheal illness. And when she showed up, her pH was 6.9. She had ketones in the blood. She had an elevated anion gap. Her glucose, once again, was just in the 70s. They didn't report her A1C, but once again, they tried to demonstrate that she was making lots of endogenous insulin because they measured her C-peptide, which was pretty elevated. Finally, I figure we'll move on to the paper that I sent out, which is this paper from UPenn, Perioperative Management of Patients Receiving SGLT2 Inhibitors, Development of a Clinical Guideline. And what they did is they teamed up with their anesthesia, critical care, endocrinology, and pharmacy departments. And they tried to make a guideline with the goal of minimizing surgical cancellation in patients who might be at low risk for developing euglycemic DKA when the SGLT2 inhibitors were not appropriately discontinued. And ultimately what they said is that if you followed the FDA's guidance and held your meds for at least 3 days, you could go and proceed with your procedure. And they said that if you didn't hold the medication for at least 3 days, but that if you weren't diabetic, you could go ahead and proceed with your procedure. And I'll just remind you that at the time that they published this, they weren't aware that there were even any case reports of non-diabetic patients developing ketoacidosis. They then said that if you are diabetic and you have to go for an urgent or emergent procedure, that they recommend measuring the anion gap and beta hydroxybutyrate. But regardless of what these levels are, they're probably going to say that you can go ahead and get the procedure, but that if the anion gap and beta hydroxybutyrate are elevated, suggesting that ketoacidosis is already occurring, you should probably start some insulin and dextrose in the OR, and you should probably consult endocrine. And that even if they aren't elevated, you still might want to consider starting some insulin and dextrose in the lab. And once again, you should probably consider consulting endocrine. And then finally, they say that if you're diabetic and you're going for an elective procedure, they actually have a qualifier that says that if you're not going to be NPO for more than 12 hours, you don't even need to check labs and they'll let you proceed. But that if you are going to be NPO for more than 12 hours, they do recommend checking the anion gap and beta hydroxybutyrate. And if either of these are elevated, suggesting ketoacidosis, you should certainly postpone the procedure and admit the patient and treat them for ketoacidosis. And that if these aren't elevated, it's still reasonable to postpone the procedure, but they do know that there are some very low risk circumstances where you still might consider proceeding. So what they say is they say there are numerous procedures for which patients may fast, but due to the short duration and minimally invasive nature of the procedure, oral intake might begin almost immediately, and that such procedures include cardioversions, cardiac catheterizations, some ophthalmologic procedures, and upper GI endoscopies. And I just want to note that even though they call out upper GI endoscopies, this isn't to be confused with colonoscopies, where the risk of perioperative euglycemic DKA is actually elevated. And here we see the case series from 2020, where they report 8 cases of SGLT2-associated euglycemic ketoacidosis in the setting of colonoscopies. Here they note that all of the patients had type 2 diabetes, and 7 of the patients had been taking their SGLT2 inhibitors up until the day prior, with one having taken it the morning of the colonoscopy. They note that bowel preparation for colonoscopy leads to prolonged periods of reduced caloric intake, which causes volume depletion and dehydration, which is further potentiated by SGLT2 inhibitors, and that these risks, especially when combined with the reduced insulin doses, can lead to DKA even before the stress of the procedure itself. That said, some of the cases that they reported here were kind of softball ketoacidoses. You'll note that for 2 patients, they didn't even mention the pH. For these same 2 patients, they treated them with just either subcutaneous insulin and feeding them, or sometimes, or in one particular patient, they didn't even give them insulin, they just fed them and it resolved. And they didn't even delay the cases for 4 of these patients. So, but that said, euglycemic DKA does seem to be, or you seem to be predisposed for it when going for colonoscopies. But UPenn notes that for procedures when minimal sedation is needed and patients will resume oral intake almost immediately afterward due to faster emergence from sedation than general anesthesia, patients likely have a lower risk of euglycemic DKA, and for these patients, some clinical services may decide that the FDA guidance is not applicable. They do provide some guidance for what you might consider to be low risk. So they say for procedures that are less than 1 hour requiring MAC, local, or regional anesthesia, if you have a total anticipated NPO duration of less than 12 hours, an A1C of less than 8, a preoperative glucose of less than 150, or you're not taking insulin in the outpatient setting, these might be considered low risk. That said, I don't really agree with all of these considerations, especially this one that says the glucose less than 150, because if we look at our systematic review of case reports, we'll see that while the median glucose was 179, the mode was actually 125 to 150. So a good number of these patients are going to have blood glucoses less than 150. But nonetheless, this is what the University of Pennsylvania is currently utilizing. They then say that if you do go ahead and proceed with the procedures, they have some considerations for if patients are admitted post-op or discharged post-op. And if they're admitted, they recommend checking a fingerstick glucose within 1 hour and then per unit protocol, and then also checking a BMP and beta hydroxybutyrate within the first hour, and then every 4 hours for the first, and then every 8 hours for the first 24 hours. And before they let these patients go home, they want to make sure that they're tolerating a PO diet that includes carbohydrates. So finally, the paper notes that before the distribution of these guidelines, there was a high degree of variability among anesthesiologists as to when surgeries were postponed if patients had not held their SGLT2 inhibitors, but that after the distribution of these guidelines and a concerted initiative to educate anesthesia and surgery, the practice became more uniform among anesthesiologists across the Penn facilities. They note that in the first 6 months since the guidelines were implemented, that only one patient ended up having an anion gap of greater than 12, and that patient didn't this patient had a normal beta hydroxybutyrate, and that this suggested that the risk of euglycemic DKA might be quite low in patients before surgery, and that checking a BMP may not be necessary in all patients who have not held these medications. They note that after discussing with their surgical faculty, they're unaware of any cases of patients returning to the hospital with euglycemic DKA postoperatively since the guidelines were implemented, and that as more data becomes available about the risks of SGLT2 inhibitor use before surgery, that they hope that they can further simplify these guidelines to minimize interruption to patient care, and that they hope that other hospitals can adopt their guidelines to provide a framework for their own institutions. So that's pretty much what I have to say about the guidelines. With respect to management, if you happen to catch a case of euglycemic DKA, managing it is really the same as management for regular DKA, where you're going to try to stop the ketogenesis by giving insulin. Of course, because the glucose levels are going to be low, the main difference is that you're going to start the dextrose right out of the gate. They do note that for patients that have ketoacidosis, they're usually very dehydrated, so fluid resuscitating them is usually necessary. But once again, because their glucose levels in this setting are usually low to start, you give them some dextrose right out of the gate, along with the insulin. And if we look at the two cases that were reported in patients without diabetes, they actually show us what happens once they initiated their treatment. So we can see that for this 28-year-old gentleman, again, his glucose was never above 200, but they started him on some D10 right out of the gate. And very shortly after starting the D10, you see that his ketone levels start to drop. And that's even before they start giving him insulin. But about 12 hours later, they start some insulin, and you can see that the ketones drop even further. And as the ketones drop, his bicarb increases and his whole acidotic state resolves. And we can see a similar pattern with the 62-year-old woman, where she had a very precipitous drop in her ketones very shortly after initiating IV dextrose. She was actually started on insulin right out of the gate, and you can see that as her ketones dropped, her bicarb increased and her acidotic state resolved. Unfortunately for this 62-year-old woman who had a reduced EF, they say despite attempts to minimize fluid administration, the patient developed recurrent episodes of pulmonary edema requiring continuous positive airway pressure, and that, in a view of minimizing the amount of fluids she got, they used higher concentrations of dextrose in an attempt to drive both her endogenous insulin secretion and suppress ketosis. But that's pretty much all I have to review today. Once again, we saw that, the main thing that kind of drives ketogenesis is this high glucagon to insulin ratio. We saw that while the number of reports of ketoacidosis are increasing, the total incidence is still pretty low. We saw that with this in mind, some institutions have become quite lenient in who they consider allowing to proceed to their procedures, even if they don't adhere to the FDA recommendations. And that if we do find a case, you really just treat it like regular DKA, except that you might start some dextrose right out of the gate. And that's pretty much all I have to discuss today. Happy to take any questions.